Hi, I'm Matthew Goodwin. I'm from WashU in St. Louis, and I'm joined here by two of my colleagues.
My name is Larry Lo. I'm from Northwell, New York.
Hi, I'm Dan Sciubba. I'm a neurosurgeon in Northwell in New York.
And thanks for joining not only my colleagues, but friends and former mentors and still mentors. So the topic today is carbon fiber implants in spinal oncology. And we could really go a lot of directions with that. I guess I'll start by saying I personally am a little bit of a laggard. I'm a slow adapter in general. I drive a Toyota. I like what's tried and true. And so I am definitely at the tail end of it, only because folks that I've worked with have cycled through it, where they've used it,
Right.
They were proponents, then they didn't like something, whether it was they don't know if they could tell if it was failing or whatever it was, and then maybe it was the price, maybe their hospital, whatever it was, and then they kind of cycled out of it and said, well, maybe we don't need it. And I feel like some people are even coming full circle and are back into it again now.
Right.
So I'd love to just hear the general thoughts on the science of it, how helpful it is, what it's most helpful for.
Sure. I think I've cycled through that phase already, if you will, but at least, the science of it is fairly straightforward, as you guys are aware. It's that basically we have these radiolucent implants that allows for better surveillance of the tumor postoperatively, especially if you're trying to hit a home run like primaries, right? And I think that in theory, the radiation delivery for a traditional titanium alloy implant, the beams need to be planned around that. Whereas for a carbon fiber, my understanding is that you don't have to plan around it like it's a titanium implant. So in areas that are a little bit more sensitive, like the cervical spine, it does make things a little bit easier from the radiation perspective. I think that most of the systems out there are a little bit flimsy. And I think that's part of the problem is that compared to traditional titanium alloy, at least sort of the ease of use, it seems a little bit less robust. And we've definitely run into our problems in terms of using the carbon fiber implants. That being said, literally just an hour or two ago, I just got sent an MRI on a patient that had a carbon fiber reconstruction for it was a protein-differentiated sarcoma. And because the implants were so didn't cause minimal streak or whatnot, the question was, the patient was having increasing back pain below where the fusion stopped at L2. And so we were able to tell with imaging that it was actually just a biomechanical failure rather than tumor recurrence. And I would say that it's certainly possible that that patient had the titanium alloy implants that we could have made that determination, but I would say it certainly was a little bit easier. The MRI was super crisp, and especially it was next to the instrumented level, so we could tell that, there was minimal diffusion signal. The stir was more consistent in the end plates. It seemed like it was more consistent with a biomechanical failure. So I do think that, I think adapting it initially was a little bit challenging. Then we had some sort of implant-related issues, but then now starting to see that first wave of patients come back and seeing that, there is utility in some long-term surveillance. I do think that perhaps at least in my practice, we're moving back to using it a little bit more.
And is it easy to tell if there's a cracked screw?
Very difficult. I think that for the system where the outside of the screw has sort of a titanium spray, it's a little bit easier, but even then it barely shows up. I would say we're talking about getting a fine cut CT with 0.5 or 0.625 millimeter slices, and you have to really scroll through there's a crack in that coating. So it is quite challenging. I do think that it brings its own sort of unique quirks of using it.
Counterpoint? Is that my term?
Exactly.
So I think that if we look at the pros and the cons, we are now later on in the hype cycle. So the hype cycle, that, as we know, we get excited and let's use it in everybody. And then I had a failure, I'm never using it again. There's probably certain situations where this is ideal. And I think, to use a common term I use, the constraints that narrow that, so it's not everybody uses it or no one uses it, are the following. The radiation oncologists are excited about this because they believe that they can do better mapping of the tumor. They can draw around it and conform maybe more easily for two reasons. One, because they can see it better maybe, and two, because there's no shielding of the particles if they use high particles and such. So there's a push from that side. Now let's look at another constraint, extremely expensive in their current situation. So now, is this really as valuable if it's not as robust? And so when we think about our implant systems, which are on exhibit at this meeting, they are on their 4th or 5th, in some cases, iteration of their thoracolumbar system, from titanium rods with claws to the new pedicle system. Maybe 4th in some of the places. I think there's 4th system in maybe Medtronic or some of the older companies. Johnson & Johnson, maybe 4th or 5th, and they're still not perfect. This is the first iteration, and so it's clunkier, and it's not as easy to use. And so in talking with those leaders of those companies, I say, you do have to rapidly get this to a comfort level where surgeons are using something they think is pretty good and still not perfect, and you're behind on that. So that's another constraint, an expensive system that might not be as reliable as the other systems. So now you have this natural tension between, is it better for the tubular control and visualization? And if it is, at what cost to the surgeon's technical and to the failure? And what I'm finding is that sweet spot for me is not usually a metastatic patient, unless it's an oligometastatic patient in, say, something that is very hard to control locally, like a renal cell. So the renal cell patients, just for the listeners, they might have a very good response systemically to their drugs, but the spine just keeps recurring because the drugs don't work well in the bone, and it's hard to see. I think for some of the primaries. But for a patient who's very sick and might not have a long life expectancy, I think the hospital might have a problem with using very expensive implants in a patient who's not going to necessarily be around that long, and their local control will probably be good compared to their overall survival. What I mean by that is the tumor's not going to come back in the spine, but they might die of lung cancer systemically, and so seeing it might not be worth it. So for me, the constraint now is primaries and locally aggressive allo-metastatic disease that don't respond well to radiation, maybe like a renal, maybe like a metastatic sarcoma, or something like that.
And so the primaries, are there ones more than others that you're thinking about at chordomas that might get protons afterwards, or are you changing how you feel about that based on the margin?
I think for me right now, I would argue the pathology, whether it's chondrosarcoma, chordoma, what have you, maybe not as important as the location. I think a thoracic lesion with a generally simple bend of one bend of the rod. These rods are not bendable. They come back pre-bent or preformed. And so that might be a great situation for that. A lot of other organs in the area, lungs are there, it's maybe hard to see. A sacral chordoma with the current system, I do not feel comfortable putting in carbon fiber because I don't feel as comfortable with its rigidity at the lumbosacral junction. And then because they haven't really evolved to the same level the other implants, occipital cervical, the implants just aren't there either. So I think at the junctions and at the extremes, I'm going to be less hopeful. But a thoracic lesion with a primary chondrosarcoma, or chordoma, or sarcoma, that's probably more of an ideal situation.
I think the geometry of the original tumor is kind of important too. I do think that typically, if the tumor is well contained within the vertebral body, you're not really instrumenting that level anyways, and you're actually probably limited by the cage type. On whether are you using bone, are you using a titanium mesh, are you using expandable cage, are you using a radiolucent cage? So I would say that in terms of the screw and rod side of things, I do think about the tumors that have significant paraspinal extension. Like if there is sort of posterior extension into the erector spinae, if it reaches out dorsally through the dorsothoracolumbar fascia, for those types of lesions, I tend to be a little bit more aggressive with potentially using carbon fiber because I do think that having less signal there is potentially more helpful in detecting a local recurrence there.
And you mentioned radiolucent cages. Your carbon fiber? Or
Carbon fiber.
Yeah. And what can you tell me about those? I'm naive.
I would say compared to the titanium expandable cages, I would say even the titanium expandable cages, they have a limited graft window compared to something like a harms mesh cage.
Sure.
So even compared to that, I would say there's minimal graft window for a carbon fiber expandable cage. For static cages, there's a little bit more, and there's static cages where you can actually directly put the screw into the carbon fiber cage. I think that's probably a little bit better for sort of a long-term union, but no question that it's much more finicky in terms of deployment compared to a traditional titanium mesh, expandable cage, or fixed cage.
All right, so let's say I want to dive in and use some on some primary tumors. How do I convince? But my hospital says no, it's 5 times as much. No way. How do I convince them to let me do it? Or maybe I shouldn't. Maybe I shouldn't do it.
Yeah, I think if you're looking to try something that's expensive and new, there's multiple strategies for that. But I think the underlying North Star is if you are having a long-term relationship with this person, whether it's your hospital administrator, your spouse, or anyone, you do want to engender some trust.
Yeah.
So if you are constantly using the most expensive thing because it's new, eventually they'll start saying no, because you're one of those early adopters who wants the newest handheld phone and wait in line for the 13th phone that came out, while others will say, I want to wait till something actually truly disruptive comes along. If you're totally a laggard, the hospital administration might like that, but your program building might not evolve, because if you're living in the 1980s, people say that program is not doing anything. The hospital bean counters might say they like you, but the program might not be building. That could be stagnant. So I think the way to go about it is, I've thought about this. This is a special case. I will give you feedback on this. This is why we're doing it. This is what some other person has done. And I'm willing to be part of any negotiation or discussion where we work together with industry and with the hospital to find a way that we can make this happen. And I think there's a million ways to do that. I think the problems are simple. So you can do, the solution is a million solutions. The problems are usually, you don't think about the bean counters and you're irresponsible that way.
No.
You don't tell them how well it worked and give them feedback that said, by the way, I want you to know, thank you for letting me do that. This really worked. And you don't look at your outcomes. And I think if you do all those 3 things, there's probably a million ways you can try new techniques, not just carbon fiber, but any new technology.
And what about, do you guys have any experience with doing hybrid constructs, or is it always a hybrid construct when you use it?
I tend to not use a hybrid construct unless it's really necessary. For example, they don't, as far as I know, the systems that are out there, they don't have pelvic fixation, so that doesn't necessarily take a hybrid construct. Sometimes the rod contouring is impossible. It just doesn't fit one of their pre-cuts, and if that's the case, I'll use a titanium alloy rod instead. But I do try to, if I'm saying that the extra mile matters in terms of how crisp the images are, I do try to keep it all carbon fiber if possible.
I see. Well, I think we're about out of time. I like that comment about how early we are in the carbon fiber compared to, we're on the 5th or 6th iteration of these other systems. That kind of gives me restored hope in some of it, in terms of some of the problems we've had in the past. So thank you both again for joining me. Great discussion, very much. Thank you.